Good morning from the Hawaiian Eye Conference in the Big Island of Hawaii. We're pleased to be here today with Dr. Kendall Donaldson from Miami, Florida, the chair of the ASCRS Refractive Committee and also a member of the ASCRS Cataract Committee. Thanks a lot, Kendall, for being with us.
Thanks so much for the invitation, Jonathan.
Kendall, I'd like to speak with you this morning about presbyopia correction during cataract surgery. We have a lot of options, and the options have been refined over the years. We have presbyopia correcting lenses, we have Monovision, we have a few others. I understand that you're speaking at this conference about Monovision in particular. Can you give us an overview about how Monovision works and why it's a good alternative to other options that are out there?
Sure. So presbyopia is an interesting thing. We can't escape it. You know, it's the most common eye condition really, and we will all face it during our lifetimes. So we have so many different options to help our patients at this point in time. We have lots of different presbyopia correcting IOLs, and we have the accommodating, the multifocal, and then of course we have Monovision, and I think Monovision kind of gets a bad rap because it was pre-existing before all this great technology came out, but still I think it has so much to offer our patients, and I find myself doing it very frequently with my patients. You know, if we reflect on the ASCRS 2018 clinical survey that we do every year, we know that the penetrance for presbyopia correcting IOLs is really only around 9% around the world. Mm-hmm. And if we look at the usage of Monovision, it's 11% for full Monovision and 14% for mini Monovision, which means 25% of our cataract surgery patients are getting presbyopia correction with Monovision, and only 9% with the presbyopia correcting IOLs.
Well, I'm glad, Kendall, that you brought up those two different aspects of Monovision, full Monovision and mini or partial Monovision. What's the difference between those, and why is that important to understand?
So mini Monovision or blended vision is more of a difference between minus 0.5 and minus 1.25 between the eyes. And full Monovision is considered minus 1.5 and minus 2 diopter difference between leaving the non-dominant eye at a minus 1.5 to minus 2. So it's a bigger difference, more anisotropia with the full Monovision.
So from a clinical perspective, how might patients notice the difference between blended or partial Monovision as compared to full Monovision? How will their distance and intermediate and close eyesight be impacted by that?
So the mini Monovision patients can get more of a natural range of vision, and I tell them that still they may need some glasses for the very small print, but they can capture some of that range of vision that they wouldn't have, maybe capture their computer distance or their watch and things like that. But a lot of them, impressively, are still able to read pretty small print. You know, for the patients where I'm doing more Monovision, those are patients that had pre-existing Monovision, maybe naturally, or a history of LASIK for Monovision, or a history of contact lens wear for Monovision. Yeah. So, and actually more of them I think are female as compared to male.
That's a good point.
Which is interesting. Yeah.
That's a great point, Kendall. And I wonder if you can speak about some of the limitations, perhaps, of Monovision. Why might a surgeon choose Monovision for one patient over another? Or what makes someone a good candidate, and what makes someone not a good candidate for this?
So some of the limitations that you mentioned would be a decrease in binocularity, but there have been some studies that show as long as you have less than 1.5 diopters of anisotropia, patients maintain binocularity. So once you go up to those higher levels of Monovision, that's where we can lose some of the stereopsis and binocularity, so between the 1.5 to 2 diopter range. So really we can still maintain that in patients. Other limitations, you do have one eye for distance and one eye for near, but it is nice to be able to trial that ahead of time in patients. Not everyone can neuroadapt, just as we see neuroadaptation results. They can tolerate a few drusen or maybe a mild macular issue, much more so than a multifocal lens that I feel can really magnify a little macular pathology in those cases. So I might prefer Monovision in patients like that.
That's a great point, Kendall. I wonder also about patients who have astigmatism. Are those patients also candidates for Monovision? Are you able to use toric implants or limbal relaxing incisions to affect the astigmatism and provide the Monovision that you described?
Absolutely. I frequently use toric lenses to be able to do Monovision in that way. And I think we're also fortunate now with the presbyopia correcting lenses. We have multifocal and ED EDOF lenses that also have the astigmatism built in. So, we can offer either of those options in a toric version.
So it sounds as if Monovision is a good option for people who want to have some maintained depth of focus and some intermediate or reading ability with their distance eyesight that may not be candidates for multifocal lenses or EDOF lenses for one reason or another. It's a good tool in our toolbox as cataract surgeons.
Absolutely, and it's much less expensive for patients too, so if they have financial limitations, it's such a great option.
Well, Kendall, this has been such a great discussion this morning. I'm so glad to have your expertise on our program. Thanks again for being with us.
Thanks again for the invitation, Jonathan.